Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm excited to bring to you a spectacular interview with Dr. Emily Kahnert and Dr. Nick Rainey. This is our first interview associated with the 2021 annual AAOMPT Conference, which was held in Cleveland, Ohio from October 7th to the 10th. The conference also included live-streamed content that was accessible for those that could not attend the conference because of either the global pandemic or some other reason. Just like previous years, you're going to hear a series of interviews with presenters from the conference. These interviews are always a little different than when we talk about a specific published paper, which means you can anticipate broader and more in-depth conversations. Speaking of which, both of our guests today are very accomplished physical therapists. Dr. Kahnert is a physical therapist at the TMD, Orofacial Pain, and Dental Sleep Medicine Clinic at the University of Minnesota School of Dentistry. Her 15 years of clinical practice have been exclusively focused on treating TMD and orofacial pain in multidisciplinary settings. She is a certified cervical and temporomandibular therapist, which is abbreviated CCTT, through the Physical Therapy Board of Craniofacial and Cervical Therapeutics. She also began working on a PhD at the University of Minnesota, studying biomechanics of the TMJ in the fall of 2019. Dr. Rainey is both a board-certified orthopedic clinical specialist and a fellow of our academy. In addition, he is also a certified cervical and temporomandibular therapist. Dr. Rainey is the founder of Rainey Pain and Performance, as well as Sierra Vista Headache and TMJ Specialists, both of which are private practices located in Arizona. Dr. Rainey also teaches a TMD and Orofacial Management Interactive Asynchronous course through Rocky Mountain University of Health Professions Continuing Education Division. We invited Dr. Rainey and Dr. Kahnert to the podcast to discuss their 2021 AAOMPT presentation, which was titled TMD, Neck Pain, Headache, Untangling the Mystery. And with that as our introduction, let's get to the interview. Dr. Rainey, welcome to the podcast. How are you today?
I'm doing fabulously. How are you doing, Stephen?
I am excellent, very, very excellent. So thank you for joining us today. And Dr. Kahnert, a warm welcome to you as well. How are you today?
Hello, I'm doing well. Thank you, Stephen. Thanks for having us.
Well, we are honored to have both of you here today. And as both of you and the audience likely already know, talking about temporomandibular disorders is one of my favorite things to do. As a result, I'm pretty sure that we're going to have some mandatory geeking out to do during this interview. Hopefully that's something the audience can support. Speaking of which, let's start off by asking a pretty simple background question, and that is, can you tell us, in your experience or your opinion, how difficult is it for this patient population to find somebody to perform an expert evaluation and hopefully successfully manage temporomandibular disorders?
My situation is probably more similar to a lot of people's situation out there than Emily's. It seems like some of the people that find me, they find me somewhat quickly. It's the people that don't find me that it's hard. They may never find me. I have a guy that I just started treating a couple weeks ago, and he's been dealing with it for 20 years. And he said, I was referred to a TMJ specialist, which always means a dentist, about an hour away, maybe an hour and a half away. And it's like, well, they didn't send me to you. And I'm like, I don't know. Even some of the dentists at that clinic have been to presentations that I did at our county dental club. It's tough to change referral patterns, and most people go to dentists first. And most of our general dentists, our family practice dentists, are not members of AAOP or American Academy of Orofacial Pain, or deal with it specifically. So they just send off to who they learned in school, send it to the dentist who deals with that. Typically, dentists who deal with it a lot are a little more apt to refer to physical therapists. Otherwise, people find me oftentimes because they knew me from a previous episode of care, or their spouse knew me from a previous episode of care, or something like that. Other than that, we get a trickling of other ones. And some of the dentists I have a good relationship with in town refer over to me. But there's a lot that just do what they've always done, refer out to another TMJ dentist, basically.
Yeah, and I live in an area where there are a lot of dentists who actually know about treating temporomandibular disorders, and people still have a hard time finding us. I think one of the biggest problems is that primary care doctors don't know enough about the fact that physical therapists can help treat these conditions. I think that dentists are taught to fix problems rather than manage them. And while we are working hard here at the University of Minnesota to educate dentists differently, it still takes a really long time for that knowledge to change. And so there's not a lot of great education out there for the general population to know what to do if you're having problems. There's a passionate group of us working to improve awareness, but even there's a recent publication that came out in 2020 by the National Academies of Science, Engineering, and Medicine that stated that there's really not enough information out there about how to get treatment for these conditions. So the short answer is that it's pretty hard for people to find proper care, even when we have these providers who are here and available, ready to do the work.
It's very consistent with my experience as well. As you've both eloquently stated, it's, pretty much, I guess, a mixed bag. Some people happen to stumble into it very quickly, very easily, and then other people, it could be 20 years later. I also find that there are those old patterns that die hard. And I think part of the problem, if we can look internally, is with our profession. Within physical therapy, a lot of people don't do this. So I think the primary care providers, the patients, the dentists sometimes learn that since we don't do or don't provide this care, then why would you send somebody to a physical therapy clinic?
Yep.
Stephen. Sorry. Go ahead, Emily.
Oh, no, I was just going to say, I think, Stephen, it was your publication looking at the state of entry-level PT education. It's just still not good. And it varies so widely in terms of how many hours people get based on this. But a lot of people will still get out of school and say, well, I don't treat that. And then they don't go any further.
And I was going to say that it's part of our profession's trying to get away from being viewed as a service line. Because a lot of times they say, do we refer to physical therapy? Well, if 1 out of 10 physical therapists in your city treat it, they've never thought to refer to any other clinics. The other clinics never said that they could do that. They don't think refer to physical therapy. That's where you have to get more of an emphasis on providers. I want to refer to a physical therapist who specializes in this. There's no other healthcare profession, I don't think, at least, the major doctoring professions. Can a doctor do this? Can a physician do this? Can a dentist do this? No, the specialist. You want to go to the people who specialize in it. And so we can't be viewed as a service line, and we need to keep pushing for that as a profession.
And to take things just a step further, it's actually pretty darn complicated because we're not just talking about the jaw. This is not just a TMJ thing, which brings me to the title of the presentation from your 2021 AAOMPT Conference presentation. What is the link between the temporomandibular joint, neck pain, and headaches?
For a lot of people, it's a huge link. Some people, it's not. You never want to get into cookie cutter approach where you say everybody that has a headache, I'm going to treat their jaw, I'm going to treat their neck. You want to make sure you're addressing the impairments that you find, whether those be biomedical impairments, psychological impairments, or social impairments. We need to make sure we address what we are seeing with the person, but there is a huge link for a lot of people. And a lot of people won't recognize it. Can't tell you how many people, it's more common, at least for me, I don't know about for either of you two, where people will get referred to see a physical therapist for headaches, especially neck pain. They're like, oh yeah, I do wear a mouth guard, but I don't have any jaw problems. Well, it's a little bit of a jaw problem, or it's always been there, and it's, they don't associate it. And sometimes it is associated, sometimes it's not. But typically, there's a bidirectional relationship between the upper cervical spine and the jaw. Upper cervical spine can contribute to headaches, whether it be migraines or cervicogenic headaches, and also TMD, TMJ pain. But there's a bidirectional relationship we've got to appreciate. And if you treat one, it can help the other.
And looking at the anatomic commonalities between these areas, just simply the fact that we have convergence in the trigeminal spinal nucleus of all of these nerve endings from very different areas in the head and neck, but then they converge right next to each other. We have these nerve anastomoses that can grow even these little connections between for example, the greater auricular nerve and the facial nerve. And so we start to have this crosstalk, and then you start to see that one condition will present and refer pain to different areas. A lot of the pain referral patterns are confusing. The sternocleidomastoid will refer to the ear, to the eye, to the face. The masseter itself will refer to the teeth. And so it becomes very complicated to differentiate between, okay, what's the source of the pain and where am I feeling the pain, where they start to present as sinus pain, headache pain, tooth pain, neck pain, and it becomes very difficult to differentiate. And then you can throw in central sensitization and everything just explodes. So the upper cervical nerves can refer pain to the facial areas. I just find it so interesting. All of these neurons are so much closer together in the head so that the nerve conduction is really fast. But then once you have especially central sensitization, that descending pain inhibition, that's supposed to tell your body, oh, wait, no, this is okay, let's calm it down, that gets impaired. So things are ramping up faster, they're ramping each other up, and then you start to lose those natural inhibitions that are supposed to calm things down. And it's easy to see why we end up with these chronic overlapping conditions.
I think those are all excellent points. And more specifically, I think it speaks to why the physical therapy profession is nicely positioned to try and address this general patient population, because we have skills in all three of those areas. We can work with people that have headaches. We can work with people that have neck problems. We can work with people that have jaw problems. And that's not true of all the professions that end up working with this patient population. Speaking of which, in terms of those management strategies that we have at our disposal, can you speak for a moment about which ones, in terms of the peer-reviewed evidence, appear to be potentially better for this patient population?
Yeah, I can start
Nick, I'll
with that
let you
one.
go ahead and start with that.
Okay. There's a lot of ways you can skin it, and I always say treat what you see. If the patient comes in there and they have very few biomedical impairments or pathomechanical impairments, but they have significant psychological or social impairments, or I sometimes call them recovery limiting factors, then you should focus on what you see. And if there's significant pathomechanical or biomedical impairments, then you want to attack those pretty aggressively. Because even if there's central sensitization, if they've had significant pathoanatomy, pathomechanics for a while, there's been a nociceptive barrage for a long time that very well could have triggered that central sensitivity in the beginning. A go-to for me is manual therapy here, which is probably not a shock being on an AAOMPT podcast. Whether that's manual therapy to the upper cervical spine, I find that thrust manipulation can be the most powerful there, particularly for the occipital atlantal joint, where most of the research is. I typically will just test if I want to hit more OA or AA there. And the research shows that improves maximal mouth opening and pressure pain threshold. And so I am looking at the neck aggressively at first, especially if there's not as much impairments I find with the jaw. Now, if I find more impairments with the jaw than the neck, then maybe I'm attacking the jaw first. When in doubt, I typically go with the neck first, unless they've already had, maybe they've seen a chiropractor, they've seen other people that have addressed there, then I'll go for something new. But if it's 50-50 and nothing else tell me, I'll go with the neck first. I find that just to be a little bit more powerful. That's definitely an art, area there. But manual therapy for the jaw, whether it be soft tissue mobilization, joint mobilization, or for the upper cervical spine.
Yeah, there are a number of reviews that have examined this question because there are no clear answers. And thankfully, we are starting to get more and more studies looking at it, but there is no one exercise or stretch or even manual intervention that seems to shine above all the others. So most of these studies end up concluding that you need to do all of it because nothing nothing stands out, but that our interventions are helpful and effective. The other conclusion that tends to be pretty consistent in the literature is that multidisciplinary care really is the gold standard, again, because no one thing jumps out, but also conservative and some non-invasive interventions are the best way to start. So because we can have such good results with manual therapy, exercise, there's really no reason to jump right to all of these irreversible orthodontic interventions or even surgeries. I think it was Dr. Schiffman's publication looking at 4 strategies for closed lock, where all of the groups improved, ranging from medical management to physical therapy to arthroscopy, all the way to open joint procedures for a closed lock diagnosis. So if you can get really good results without going for the maximum invasive surgery, pretty irresponsible to start with something like that you can't reverse. There was an interesting review that came out in 2020 that showed while manual therapy definitely is helpful, at least in the short term, when you combine manual therapy with exercise, those effects last longer than when it was just either intervention alone, which we know as PTs. This is not a surprise for us to hear this. But I think that's the biggest take-home message from those management strategies. Most of them show that manual therapy is very helpful and successful. And then we need to make sure we're combining it with exercise and education, getting the patients involved in their own care in order for those effects to last.
That is all very consistent with my understanding of the literature as well, and in addition, of course, my clinical practice. But the reason we're here today is because we've invited you to talk about this presentation and how you, in this presentation, describe the care of different patients. So I know that you talked about 3 different cases in the AAOMPT Conference presentation, but let's focus on case number 2. And let's start by asking, who was this patient? What were their variables? Can you please give us a description so that we can then go through the rest of the examination, treatment, and outcome findings?
Sure, and I will jump in here because this was my patient, and I think her history will probably sound somewhat familiar to both of you. But she is a 28-year-old female. She's a nurse in the ICU. Before coming in, about 6 months before, she had started working nights. So her previous sleep patterns were disrupted from what had been her normal routines. She was engaged to be married, so she was in the process of wedding planning. She did also have a history of anxiety, used to bite her fingernails when she was younger. She definitely recognized that she was clenching her teeth and holding a lot of tension in her jaw muscles. And she was experiencing locking in her left TM joint with limited opening that had recently started before she came in to see me. So she used to have clicking. She'd feel some resistance. She'd push through it and get a click, but that clicking had stopped. She couldn't get open anymore. And she also was having these headaches in her temples on both sides. She had pursued treatment for her headaches independently before coming in to see us for her jaw, but it hadn't really helped to decrease any of those symptoms. And then she did also have constant neck pain, tension pain, nothing that she had really sought care for before, but she definitely noticed that while looking down at her patients in the ICU all day long, when trying to find a comfortable sleep position when she was finally home after those nights, that her neck was bothering her.
And while there are a lot of different presentations, of course, because when we say temporomandibular disorders, we're really talking about this big umbrella category, a heterogeneous group of musculoskeletal disorders. This to me sounds like a relatively classic case. I'm sure all 3 of us have seen this type of thing over and over and over again.
Mm-hmm. Yeah. And again, what's just so interesting is how long it takes a fairly classic presentation type of patient to find appropriate care, because providers understand headaches, and so they will start there. But none of them had really thought to ask her if she had anything going on with her jaw, and she never thought to tell anybody that this was something that was going on. And once she came into our clinic, we were able to established some of these connections between her jaw problems, her temple, and even her neck pain. It definitely fell into place.
Speaking of which, when you dove into that examination, what were the specific findings you found with this patient?
Mm-hmm. So her jaw opening actively, she was limited to about 27 millimeters. There was no noise, but there was an obvious deflection of the jaw where she was moving off toward that left-hand side, and it was not returning back to midline. When I passively stretched her open, we got to 35 millimeters before she needed me to stop because of pain. And it didn't click. And so the way that I'm looking at this, 40 millimeters tends to be that cutoff for normal opening. And I was pretty certain with that hypomobility, she'd had it for a little while. We could stretch into it, but she still was not reducing around that disc. When she would move her jaw laterally, she could move toward that side, no problem. She was going 8 millimeters to the left. But then when she tried to move away from it, she was limited to 4 millimeters to the right, and that reproduced her familiar pain on that left side. Also, very interesting finding was that as we were measuring her active range of motion, she reported that her familiar temple headache was increasing. And that's one of those big things with our diagnostic criteria. If active movements and movement of the jaw reproduce that headache, then that classifies it as that TMD type of headache as opposed to just a tension type headache or something like that. When I was testing her TM joints passively, that accessory motion testing, she was normal on the right side in distraction and then anteromedial glide, but she was limited on the left. And when I palpated her masseters, that left deep masseter especially reproduced her familiar pain. The medial pterygoid, which I went at extraorally but also could palpate intraorally, reproduced that familiar pain and even some pain into her ear. And then temporalis on both sides, when we palpated that reproduced her familiar headache pain.
I can see the picture of this patient in my head as you're talking about it, and honestly, I wish they were in front of me so that I could start treating them, but
I know, right?
Based on what you saw during that examination, what treatment techniques did you implement? And, if you would, let's talk about which one did you implement first, and then how did the plan progress from there?
Right. So whenever I see somebody like this, my first instinct, I just want to jump in and mobilize the heck out of that jaw and get them opening again. But you ask a really good question, because I think, for me at least, the most important thing to start with is education for these patients, explaining what's going on and why, talking about self-care, joint protection, the clenching and that tightness that she had in her jaw muscles and her face all the time. Because I can mobilize and get her opening better, but if she goes home and just continues all of these habits that have been flaring back up her muscle tension, that lateral pterygoid is going to just keep on overcompensating on the right side and staying on break on the left side. So I always start with self-care, tongue up, teeth apart. I have my patients feel their masseters to recognize, is it hard or is it soft? And for her especially, rock solid masseter on the left side with that very telltale trigger point that she could feel. But the right side was actually softer. And by having her feel it with her fingertips and asking her, is it hard or soft? Comparing to another part, sometimes the thenar eminence in the hand, that's a lot squishier. It's a good example of a more relaxed muscle. She could instantly pick up on that difference. And then when I would have her do that familiar tongue up, teeth apart positioning, I really like to encourage, let your tongue float, take a big exhale, imagine marshmallows or bread dough in your face while you do a little bit of gentle massage and see if you can feel those muscles start to soften. And she could. So that awareness, cueing them, make sure that they're chewing the food on both sides at the same time, as opposed to chewing on one side, which is what we all tend to do, but that throws off the muscle balance. And we know that when we put food on both sides and chew symmetrically, we get more symmetrical masseter activation and it balances out the forces on the joint. So I spend a lot of time with that first visit going through those pieces of education with my patients, introducing self-massage, holding their hands down the sides of their face to stretch before they just start cranking on it. And then I always will introduce controlled rotation as an exercise at the first visit because we need to get that jaw opening straight again. And Nick, I know that that's your, keeping that jaw straight is one of the first things that you look at too. If we allow the pterygoid on the opposite side to keep translating forward and compensating for that restriction on the left side, it's never going to change. And so then I usually will introduce joint mobilizations sometimes at the first visit. Someone like this who is a little bit more straightforward, after we get those muscles to release, then I will start with joint distraction, seeing if I can start to stretch out that joint capsule. But I do find that if their muscles are still pretty guarded and tight, I don't have a lot of success right away with those joint mobilizations. So I will frequently introduce heat at home because heat helps those muscles to relax. I'll put heat on first in the clinic if I have time. Otherwise, I do find that I can usually get them to relax pretty well with some manual soft tissue mobilization first, and then I can go right into those joint mobilizations, ideally in distraction, anteromedial glide. For the home component, I like to have them stretch in a few different ways. I like to use a knuckle or 2 fingertips for stretching out, but I'm a stickler about making sure that they have regained straight jaw opening with controlled rotation before I start having them jam their fingers in there. Because if they sacrifice the straight opening to get as many fingers in as they can, once again, they're just going to flare up the initial presentation of their condition. And it doesn't matter if I can get them to 40 millimeters if they're still deviating off to that left-hand side. One of my favorite interventions for joint stretching at home is to pile up tongue depressors. We'll put them in a glove so that it's contained for them. And then at home, I have them lay with heat on for about 5 minutes first, and then use controlled rotation to open while they slide those tongue depressors back there, aiming to get 12 tongue depressors between their back teeth without clicking or deviating to the side. And then they can even use those tongue depressors to do a little bit of self-distraction mobilization, which people love because then they're in control. And they can perpetuate the improvements that we get in the clinic by doing that at home. And then I always make sure that we're doing postural exercises. This woman's posture was in that very typical forward head position. So we're doing those chin tucks, scapular retraction down and back because she's spending so much of her day looking down. We need to get that head back up right again.
And when all of that was said and done, when you had the interventions completed, when they did the home exercise program, what type of outcomes did you get with this patient?
After about a month or so of seeing this person, really not even every week. So I will say, perfect world, if we could see these people twice a week to do these interventions and get them stretched out, I think the timeline would have been even faster. But I was only able to see her about twice a month. So by that third visit, she was opening to about 41 millimeters without pain. Passively, she could get herself up to 45 millimeters. We had gotten her lateral movements back to be equal between the two sides. Her headache was significantly better. It had gotten down pain level to 1 out of 10, and she had significantly less neck pain. And she was able to chew, yawn, talk, have normal jaw function without pain. She was no longer worried about having dental work. That was just after 4 weeks. I did keep seeing her for a long time because we wanted, not a long time, but I kept seeing her longer than just a month because we wanted to make sure that those improvements would persist over time. And when all was said and done, we did about 10 weeks of therapy with 8 total visits, and she was feeling about 99% better by the end and feeling really comfortable about her ability to manage this going forward.
That sounds like a great outcome. It's the type of outcome that I think any one of us could hope to have with any one of our patients, TMJ or otherwise. And based not just on this case, but both of your clinical experiences when it comes to temporomandibular disorders, what type of clinical practice advice do you have for those physical therapists that want to take a deeper dive into the realm of temporomandibular disorders?
I'll take that one to start off with anyway.
Yep.
Some of it's just being brave if you've been worried about it. There's a lot of people say treat the neck even if you don't know it had anything to do with the jaw. There's definitely something to that. There's a lot of research indicating treating the neck, and most physical therapists are more comfortable doing that. The other thing is, don't be scared of it. I like to say, can you think of any other joints in the body where there's two bones and a soft thing in between? I mean, there's a lot of place in the body, particularly knee and spine. And now this one
Mm-hmm.
has had, two-sided to it, so it's a little bit different, and that soft thing does move. But play with it. You're not going to do anything that's going to irreparably harm them. I find a lot of repeated motions, do quite well. If it's crooked, like Emily said, try to straighten it out. It's probably
Mm-hmm.
going to give them some benefit if you straighten it out. So somewhat be brave. 2 is search out educational offerings. There's not a ton of, at least not as common as some other things, but there's lots of things you can read. I teach an online course. There's other live courses. I know the Physical Therapy Board of Craniofacial and Cervical Therapeutics keeps a list of courses that are offered out there as well. It's not totally comprehensive, but there's a number of them there. And you learn a little bit, and you can go and treat a lot of people.
Right. I 100% agree with what Nick says, because my situation is a little more unusual, where I've been exclusively treating TMD and orofacial pain for 15, 16 years. And actually for me, I feel sometimes like I'm a little bit scared to venture out of my comfort zone and look at some of these other joints. But the biggest thing is that it's a unique joint, but it is a joint. And as physical therapists, our specialty is looking at movement patterns, movement disorders. And by using our assessment tools, paying attention to how it moves, what do you feel, we can affect a lot of change for people. The other factor with this, and a lot of the research looking at therapeutic alliance and patient involvement in care, patient education, is pretty strong. Just having a provider who listens to them, especially these patients who have fallen through the cracks of the healthcare system and frequently been told, well, the only fix is for us to pull all these teeth and change your bite, and basically these interventions that they have no participation with. But just having somebody who starts to say, hey, look, here's how you're moving, and here's what I notice, here's what I feel. You can get a whole lot done, even if you don't know exactly this anatomical piece and how much pressure am I putting on and what intervention am I doing here. Postural work, awareness, and patient education goes a really long way.
I really love that advice, and it's consistent with what I teach when I'm teaching. Just to pick out a few quick points there. Like you said, it's not that complicated. It's just another joint. Yes, it's somewhat unique, but we do this every day, all day long with other anatomical regions. So we just need to dive in, use our general musculoskeletal skill set. And then I think it's important as well, as you've mentioned, find a course, get a good mentor, make sure you're having someone help you along the way so that you can take all of those skills that you already have, most of which they're in your entry-level education, they're in your post-professional education, and you just have to fine-tune them a little bit and make sure they're specific to the temporomandibular joint.
I will add that I think the pandemic has introduced a lot of opportunities in terms of here at the University of Minnesota, at least, we are starting to think about possibly some consulting services with other physical therapists now that everybody's comfortable with Zoom. I've actually had a number of times that PTs in outstate Minnesota have reached out to me, and we'll do a quick Zoom call and they'll talk through, hey, here's what I'm seeing. Any suggestions, ideas? What else can I do for this patient? And even the options that hopefully will be available for telerehab, that we can work with patients, and then they come to see me from far away, and then I connect with a therapist close to them, do some consulting, and then empower that therapist to continue working with this patient. Because I think once PTs start to get their hands in there, start figuring out, like we all just said, it's just like another joint, that's when the success starts to come. And then the barriers fall pretty quickly from there. So To anybody who's interested, I would just say start searching online, find some names. Even if there's someone pretty far away, they may know someone who they can refer you to for a course nearby. Like Nick said, the PT Board of Craniofacial and Cervical Therapeutics, they've got a list of online courses. They even have a list of certified therapists. Nick and I both hold certifications through this board, and they keep an online list of people that you can search by geographic location. So reaching out to someone nearby, just sitting down and talking with them, hearing their treatment philosophy, that's how we work to collaborate and share our knowledge and to help breaking down these barriers.
I'd also like to add that you don't have to be an expert to treat everybody that walks through the door with this to be able to help a lot of people.
Mm-hmm.
It's my experience that a little bit of education, you could treat 80 to 90% of the people that come through the doors. I treat people with shoulder pain all the time. I've not done an upper extremity fellowship or, an overhead athlete fellowship, right? I mean, if you were to put an MLB pitcher and said, hey, he's got 6 weeks, he's got to get back, what's the best thing? There's somebody else out there better than me for that. But, there's going to be people that walk through the door you may not be able to help, but you can help, at least 8 out of the 10, the next ones, with not too much extra training.
I think those are all great points. And as we're coming to a close with the interview, I'd love to know if either of you have any forthcoming research projects that you can tell our audience about.
I have two that I would like to mention. The first one is just my own research. I'm a second-year PhD student here at the University of Minnesota, and hopefully starting in January, I will begin enrolling patients for my clinical research dissertation project, which will be looking at telerehabilitation for people with TMD. And a lot of us jumped to using it during the pandemic. I think we all thought there's no way this is going to work. And actually, a lot of the patients I worked with were very surprised at how well it did work with giving verbal cues to do some of the manual interventions. So there's no research looking at telerehab in this population, and I am hoping to compare outcomes between telerehab and in-person PT for this population. So that's one piece I'm working on. And then the other one that I'd like to mention, and actually even put out a call for some help with, but part of a group through the PT Board of Craniofacial and Cervical Therapeutics that is working to develop a clinical practice guideline for treating TMD. And our proposal has been accepted by the Academy of Orthopedic Physical Therapy and is in its early stages. And that's one of the other barriers, I think, for PTs as to why people aren't jumping in, is that we don't have a clinical practice guideline. There are a number of different philosophies that all are variations on the same theme. But if we can develop a guideline to show physical therapists, all right, here's the clinical reasoning process to go through, to have one that does include these cervical considerations, to take the existing diagnostic criteria and really adapt it for physical therapy use, I think it will definitely increase the comfort level for a lot of PTs to be able to see these patients. So we will definitely be looking for additional helpers to screen abstracts, rate levels of evidence within the next year. And I don't know how to tell anybody to contact me if you're interested, but there is research hopefully coming down the pipeline with this, and we want to make sure that people have the right tools to be able to treat these conditions.
Well, those all sound like great projects, and we'll be sure in the show notes to link to both of you as presenters. At a minimum, we'll include your emails, so any audience members that want to reach out can do that. And, if I may say so, Dr. Rainey, Dr. Kahnert, it has been wonderful having you both on the podcast today. Thank you so much for joining us, and thank you for all the work that you do on the topics related to TMD.
Well, thank you for having us. It's so much fun, like you said, to nerd out a little bit and talk to others who enjoy doing this work.
Yes, thank you, Stephen. I enjoy listening to the rest of the podcast. It's an honor to be on a podcast that I listen to so much.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AAOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AAOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.